So stop here on red, inflammatory conditions of the mouth. So, I'm sure some of these things are a lot of cases you guys have seen in the past. So, ouch, we've all seen this cat comes in, not eating or bad smell, whatever it may be. We open the mouth and it's, fire engine red. So some of the topics we'll discuss: periodontal disease. We're going to just do a brief overview on this. This is something that, I don't want to beat this too much, but it is some highlights that I want to talk about. Then we'll go into two of the most common inflammatory conditions of the mouth. So feline chronic gingivostomatitis and then canine chronic ulcerative stomatitis. I'll also share a case at the end that's a bit of a gee whiz. So periodontal disease, I'm pretty sure we can all smell this slide. This walks in the door and the waiting room clears out. This is my bread and butter and day to day here. So we have nice bridging calculus, some foreign material there, really inflamed gums. This dog is going to feel a heck of a lot better when we're done with it. So more than you ever want to know about plaque. So plaque is a biofilm. And I think it's important to discuss this just to understand why animals get periodontal disease. So basically, it's an organic matrix of proteins, bacteria, lipids, cellular debris, and extracellular polysaccharides. And really what that does is it forms a coating that allows for this complex cooperative community of bacteria to kind of isolate themselves onto the tooth surface and evade host defenses, which is why plaque is such a challenging thing to address, because it really does not respond well to the body's attempt to clear it. And the reason that it can evade the host defenses is because the tooth has no blood supply and does not turn over cells, which is an interesting thing to think about. It's the only portion of your body that doesn't do that. There's no cellular turnover. The body can't reach it with inflammatory cells. The only thing that can potentially mimic this is an implant in a dog with orthopedic disease. So say we put a plate in or something like that, a biofilm can form on that. But other than that aspect of things, it's pretty much just teeth. So plaque biofilm protects itself from oxygen, and it allows that subgingival plaque. So we have plaque on the tooth surface, and then we have additional plaque underneath the gum line, which is probably the most important portion to us when it comes to periodontal disease. And that plaque on the tooth surface actually protects the plaque underneath the gum line, and it allows for gram-negative anaerobes to form, so meaning bacteria that don't require oxygen. This aspect, the reason it's highlighted gram-negative anaerobes, what bacteria cause periodontal disease, or at least the trigger for periodontal disease, changes constantly. So 1 year there will be a culture study that proves it's gram-negatives, where the next year a PCR study will say it's the exact opposite. Regardless of what it is, it's the bad bacteria that form underneath the gum line. And the biofilm is super interesting because it's crazy diverse. So it differs not only on which portion or surface of the tooth it is, which bacteria proliferate there, but also within on the tooth day to day. So depending on what is around in the environment of the mouth, that bacteria changes drastically. And that's important because we're talking about antibiotic usage. We're talking about, how are we going to, target these bacteria when they're diverse, they're constantly changing, and they're impossible to contact with the body's own immune system. And so it's really an interesting thing. So what's that smell? So bacterial products such as ammonia, volatile sulfur compounds, which are the ones that really cause the smell, and proteolytic enzymes contribute to the destruction of the periodontium. So there is some bacterial products like this ammonia and volatile sulfur acids and things of that nature that will cause some of the inflammation and destruction to the supporting structures of the tooth, causing periodontal disease. But the reality is the thing that causes the most problems with periodontal disease is the body itself. So the host's own inflammatory response is directly responsible for tissue damage and osteoclastic activity. So we can see over here in this radiograph, there's a ton of horizontal bone loss. We can see furcation exposure in these teeth, also periapical lucency, which is very likely a periodontal lesion that has worked its way down this root system and then caused infection in the central portion of the pulp of the tooth. So, it's really the body's response to this bacteria that causes this abundant amount of inflammation and destruction. So just some helpful hints regarding periodontal disease. So something I hear all the time when people come in and they're like, hey, I say, hey, your dog has periodontal disease. These are some of the concerns. Here's this brown yellow calculus that's formed on the tooth. And the owner's like, okay, well, then I'll start brushing. Really not a great idea, because you cannot remove that mineralized plaque from a tooth surface once it's formed. So once it's become calculus, meaning that plaque has started to introduce mineralized material into its matrix there, it can no longer be removed by home care. And some people say, oh, well, I can just crack that off, right? And we can scale it off. Yeah, but that's a bit like pulling the weeds pulling the leaves off a weed and leaving the roots in place, because really that subgingival plaque, that stuff that forms underneath the gum line, that's the stuff that causes periodontal disease. So when we crack off that superficial portion, we're leaving the roots in place to allow for that calculus and plaque to build up immediately thereafter. And really, I would say that it's contraindicated to start home care in the face of disease or calculus, because those teeth and that supporting structure of the teeth, that gingiva, is sensitive at that point. So why are we going to start brushing when there's active inflammation? The dog or cat is going to be really averse to that, and then they're not going to tolerate brushings long term. So really, we need to treat the underlying disease first. Once things have calmed down, then initiate your home care. So annual anesthetic cleanings and home care are the mainstay of treatment. So an annual anesthetic cleaning shouldn't just be like, hey, getting your patient under, we're scaling off this plaque we see, and that's it. No, it should be a sedated oral exam that includes feeling the local lymph nodes, looking at the soft tissues, looking at the tonsils when you intubate. Dental radiographs, super crucial. There's countless times that I can look in a dog's mouth and, I'm doing just a normal awake oral exam and I say, oh, the mouth looks pretty good. Let's just, hopefully we're just dealing with the cleaning here. Radiographs and x-rays will tell us more. And then I see a lot of bone loss in certain areas that would have 100% would have missed without them. And a dental cleaning. Now, once that's done and the patient's recovered and doing well, then we advise daily brushing. But just like I tell myself, I'm going to work out every day, the reality is hopefully I get to it 3 times a week. And studies have shown that 3-time weekly brushing is comparable to daily brushing as far as gingivitis scores are concerned. Not quite as good, but I think if people can get to it a few times a week, you're going to be doing a lot of service to that animal. So following a cleaning, and this is an interesting thing to discuss with people as well, or your clients, is that salivary glycoprotein, so that kind of sticky stuff, adheres to the tooth surface within seconds after a cleaning. Bacteria colonize within hours, and a plaque biofilm forms within 24 hours and matures in days. So this is that circumstance where and this happens to some degree, is like, hey, I'm doing a biopsy on this patient. I've done a full cleaning, and then we're looking at that patient about a week later, and I'm already seeing some kind of, slightly mineralized portion of plaque forming on their tooth by that, 10-day period when I'm maybe re-anesthetizing that patient to, remove the mass or doing a definitive type of surgery. So it really forms fast. So if people are not, your clients aren't initiating brushing relatively quickly after that cleaning, you are going to develop plaque quickly. So it's not good enough probably just to do anesthetic cleaning. You need to also advise home care. If clients follow through or not, but at least advise it. So something that probably a lot of you have seen, feline chronic gingivastomatitis. So stomatitis classically. And that is characterized by an inflammatory immune-mediated condition characterized by oral ulcerations at the tooth mucosa interface and caudal pharyngeal mucositis. So that's pathognomonic, right? That caudal pharyngeal mucositis. So that nasty inflammation there towards the back of this cat's mouth. We can see it's kind of proliferative, really red, back in that vestibule in the area of the soft palate. So let's nerd out here for a second on what we're dealing with as far as stomatitis is concerned. Unfortunately, the pathogenesis is not entirely understood. It is thought to be an inappropriate immune response to a normal oral antigen or a relatively benign oral antigen. So that's the bacteria that would normally be in the mouth or on the tooth surface, or an infectious agent that we would normally see. Some cats would have some mild inflammation associated with it. Other cats form this big abundant response, and that's these stomatitis cats. It's likely multifactorial infectious agents, periodontal disease, food allergies, hypersensitivity. I will kind of touch for that periodontal disease portion. You're going to often see these patients that are 1-2-year-old cats that you take a peek in their mouth and you're like, wow, that's like some brick red gingivitis, minimal amount of plaque, or maybe even abundant amount of plaque. And it's important to note that, because I do think that stomatitis is probably a bit of a spectrum when it comes to periodontitis to gingivastomatitis. So I'll consider those cats sometimes juvenile periodontitis cases, because they don't have that pathognomonic inflammation way in the back of their mouth, but have really brick red gingivitis. And I do tell those clients, hey, listen, we may not be there yet, but it's really important to start initiating some of these preventative measures, because your cat is on a path to potentially being one of these stomatitis cats. Studies have shown that multi-cat households are overrepresented in these stomatitis cats. I think that potentially could lead to this infectious agent portion, right? So these animals are sharing environments. So are they possibly cross-infecting each other? Also, are these, we're talking about some of these hoarding cases where this study was partially came from. Are these genetically related individuals? And so is there some underlying condition associated with that? Some of the infectious agents that we've seen, or at least have heard, are these a portion of stomatitis are calicivirus, herpes, feline leukemia and AIDS, Bartonella. The reality is the only one that has been associated with stomatitis is calicivirus. And I also want to say that's an association. It's not that calicivirus causes stomatitis, or at least that's not what we think at this point. I don't know that a study will ever come out in my lifetime that confirms what actually causes stomatitis, but I will tell you that a higher population of cats that do have stomatitis are also PCR positive for calicivirus. Okay, so there is an association, but not all cats with stomatitis are positive for calicivirus. Now, cases of refractory stomatitis, which we'll talk about a little bit later, have an association with feline foamy virus, which is a retrovirus, I believe, that doesn't really have a massive pathology or pathogenesis that we're aware of. But we do see that these refractory stomatitis cats, ones that don't respond to treatment, typically are positive for feline foamy virus. And there are specific increases in inflammatory mediators in these stomatitis cats. So the caudal mucosa biopsies that have been taken and samples have shown an overexpression of CD79 and CD8 cytotoxic T cells, which do point towards a viral component. Those are typically the T cells that respond to virus. So that's something to consider. It kind of points in that direction of, what virus is doing this. So clinical presentation, halitosis. So these owners note this acute onset of bad breath. They're like, hey, they've always had really nasty breath. Oral pain when eating. So these cats start to chew and then they like almost like wince and run away from the bowl on occasion. They yawn and vocalize. They have an unkempt hair coat because they're trying to avoid using their mouth. They're drooling with, plus or minus blood. They have reduced appetite or anorexia. That's one that we sometimes don't see. So I have seen plenty of cats with really nasty inflammation in their mouth, and they're eating fine. So that wouldn't necessarily be one, but I will say say that it is important to note that if you see nasty inflammation in a cat's mouth and they're anorexic, I would be more concerned that you're looking at an inflammatory condition like a stomatitis or ulcerative condition than I would periodontal disease alone, because it's uncommon that periodontal disease as a sole contributor causes anorexia. So that's something, and that's across the board, dogs and cats, very uncommon. The only time that I would say that's true is if there's really a nasty active abscess, or if you're seeing such mobility in those molars that they're shifting out of place and causing an uncomfortable thing when they're chewing, or locking the mouth kind of open. Those cases can be anorexic, but it's pretty uncommon for periodontal disease to cause anorexia. And then generalized lethargy. So these cats kind of feel crappy because there's inflammatory mediators spreading everywhere in their body. And that's not, preserved only for this condition. Just periodontal disease that's really significant could cause lethargy as well. That's why these old dogs who you treat their mouth, all of a sudden the owner's like, hey, they're 5 years younger. And that's because they're no longer feeling those inflammatory mediators spread throughout their body. So the oral exam is super important, and it's important to differentiate this condition from oral tumors and severe periodontal disease, because like I said, there are some crossover for these things, especially the tylism and the unkept hair coat. Oral tumors do that. So, I would look for, you're also kind of looking for squame, right? So when you're looking around these cats' mouths. So the buccal mucosal and palatal glossal ulcerations are classic for this condition, plus or minus lingual ulceration. So sometimes you'll see some ulcers around the border of the tongue, kind of in the areas that would contact the tooth surface. Now, if you see dorsal lingual ulceration, so kind of on that surface of the tongue, and you're not seeing as much, generalized inflammation through the mouth, you should also be thinking of just primarily a calicia or herpes virus upper respiratory infection, which can be transient. So just when we see these ulcers on the tongue, also look at that dorsal surface, because that can be indicative of potentially a different condition and wouldn't require the same type of treatment. There's typically an increased severity on the carnasial teeth and caudal pharyngeal mucosa, which we already talked about a little bit. The carnasial teeth lesions are likely because they're the biggest teeth in the mouth, so they're just allowing more plaque to form on them. So that's the natural area where you'd have that over response because there's just more bacteria there. One thing I will say as like a helpful hint when you're looking at these cats and you're trying to differentiate, like, hey, does this cat just have a raunchy gingivitis or is this gingivastomatitis? And maybe they don't have that really classic caudal pharyngeal inflammation, is if you see this cat up here, if you look at the almost up where the root is in the juga of this canine tooth, see how it's brick red, like almost the entire length of that canine root? I call that kind of like the racing stripe or the stripe sign on that canine tooth. And basically the inflammation is following that entire root surface. And I think that is kind of classic, or I'd be willing to call that cat stomatitis as opposed to just periodontal disease when they have that brick red gingivitis there along that surface of that root system of that canine tooth. So diagnostics, none of them are perfect. So CBC Chem, UA, you may see an inflammatory leukogram, you may not. Hyperglobulinemia is one that I see a lot in stomatitis cats. So if you're seeing a young cat that's coming in and the globulins are pretty darn high, and you're like, hey, is this an FIP cat? Open its mouth. Take a look if there's a lot of inflammation in there, because stomatitis cats can give you a pretty abundant hyperglobulinemia. And there may be a phase shift. So you may have some low albumin in that reading as well. Dental radiographs, they can range. So some of these cats are normal because it's really not a primary dental condition. The teeth themselves are often the innocent bystanders in this condition. So it can be normal, or they can have severe alveolar bone loss secondary to that inflammation, like this case here on the right. If you biopsy that tissue, you're going to see lymphocytic, plasmacytic inflammation, pretty nonspecific. They'll call it stomatitis. But one thing I want to you to be cautious of is that stomatitis really just means inflammation of the mucosa of the mouth. You can have inflammation in the mucosa of the mouth for a variety of reasons, okay? So you need to take that with a grain of salt, because yes, your biopsy may come back as inflammation, but you need to take that whole thing into a clinical picture. Is there generalized inflammation? Is there that caudal erythema towards, that palatal glossal area? Because you're going to get these biopsies back in a lot of cases if you just see like a red portion on the mucosa of the lip, even in your normal periodontal disease cases, and you take a biopsy of it, it's going to come back lymphoplasmacytic inflammation, and you're going to say, oh, that's stomatitis. Not necessarily. And the reason I would take a biopsy, because I'll be honest, I don't take a biopsy in all these cases, is if there's asymmetry. So one side is significantly worse than the other. If it's proliferative, because some of these guys get like they almost have cauliflower in their mouth, that inflammation gets really abundant and proliferative. And if the presentation's odd, so it's not following some of these things that I told you about what clinical signs I'm looking for, because I need to differentiate this from some other things. Because one of the things that does cause this inflammation that's generalized is cancer. All right. So you can have lymphoma as that's the one I think about most. That would cause generalized inflammation in the mouth. So if I'm worried or I can't be sure, I will biopsy these tissues. Here's a good example of where we're seeing a relatively normal radiograph and really nasty inflammation. So this cat has abundant, mucositis towards the back of its mouth, really significant, almost proliferative gingivitis everywhere. This is a slam dunk stomatitis cat, young cat. And here on the right is this radiograph. Maybe there's there is some mild alveolar bone loss on the distal root of that last molar back here we can see. But other than that, if I took a radiograph of this cat's mouth and it had a relatively, didn't have this abundant inflammation, I'd say, okay, there's some mild periodontal disease here. But in reality, my clinical picture is, yikes, this is an inflammatory condition. This isn't a dental condition. So how do we treat this? It's really aimed at controlling the plaque and bacteria. And ideally, it's by the mechanical removal of this plaque via brushing. But by the time we see these cases, this may not be an option. And that's because it's very challenging to have this mechanical removal in the face of active inflammation. So if I wouldn't recommend, you have this 2-year-old cat comes in, has nasty inflammation, I wouldn't say, okay, start brushing. Like that cat is never going to tolerate that. And those people are never going to be able to remove that plaque appropriately. So what you really should do if our goal is, hey, I'm on the edge, I don't know if this is stomatitis or juvenile periodontal disease or periodontitis, get them in, do an anesthetic cleaning. The anesthetic cleaning, removal of that plaque and that making sure we're getting that subgingival plaque with the curette, letting that cat kind of go home, settle for about, 5 to 7 days, let that inflammation go down, because it will. Once you remove that plaque, it should reduce inflammation, pretty significantly, then have them start home care and regular brushing. And I'm talking about if you're thinking a cat is potentially a stomatitis cat and you're trying this mechanical removal of plaque as your first step, they have to do daily brushing. Absolutely daily brushing. There's not a 3 times a week in this circumstance, because your cat's having basically a really abundant response to just even normal plaque that develops, as we know, within 24 hours. I would not initiate medical management without a surgical plan. So if you see a cat like that nasty inflamed cat we just saw in the previous slide, and you're like, hey, I'm going to start antibiotics, I'm going to start a course of steroids, it is going to respond. That cat will get better in the short term. But once that stops, once you stop those antibiotics, and antibiotics help because they reduce the normal bacteria in the mouth, and so there's less to respond to. Steroids help because it reduces the inflammation. Once you stop those, it'll come back. And then we're looking at this nasty, abundant inflammation again. And when I get these cats in for the definitive procedure to help this, they're more likely to fall into that refractory category, meaning even when I do surgery, they don't respond like a cat who hasn't seen medical management. So if we're starting medical management on stomatitis cats before giving the discussion of, hey, here's the definitive plan or here's the long-term plan for surgery, we're probably doing them a pretty big disservice. So how do we fix this? The removal of plaque retentive surfaces, and those are teeth. So get the teeth out of there, and that's curative in 70% of cats. So that ranges. I would say 60 to 80% of cats respond just to extractions alone, and that is confirmed exodontia, so removal of that tooth, and x-rays after, then also smoothing that underlying alveolar bone. So we don't want these pointy bone spurs sticking up, because cats will still have inflammation and will be really reactive in their mouth if we don't smooth over those surfaces after we extract teeth. Now there's two camps. Either we take all the teeth out or we take the molars and premolars out. And that kind of makes sense. Like, I understand why some people fall into the molar premolar camp, because most of the inflammation is caudal. I will say I am not in that camp. I'm in the full mouth camp. And the reason that is because even though we've done studies that compare these two groups, and they are comparable, the response rate is comparable, is that we don't confirm cats as refractory, meaning inflammation, even after we've extracted the teeth, until all the teeth are gone. So let's say we do partial mouth extractions. The cat still has inflammation. Our next step is, okay, we're going to put you back under anesthesia. We're going to remove the remainder of the teeth, and then we're going to see how you respond. So if that is the stepwise process, why aren't we getting the teeth all out in the first place? Now, unless this cat is defending itself or hunting its prey and is a cougar, there's no reason for it to have its teeth. Cats do phenomenal as domesticated cats without teeth. I'm a dentist. I want to save teeth, but in this particular condition, I don't think that partial mouth extractions are necessarily in the best interest of cats. Also, because this study was comparing partial mouth to full mouth extractions, but what it never did is it didn't take that partial mouth group and then extract all their teeth and see what percentage of them then completely responded. So it was a good study to tell us, hey, they're probably comparable, but it wasn't perfect by any means. So I'm more in this full mouth camp. So refractory stomatitis, what is it? So it's persistent caudal erythema and mucositis and pain following complete confirmed exodontia. I think an important portion of this is end pain, because sometimes I will do full mouth extractions on cats. They will have a significant response. Their inflammation is reduced by, 60, 70%. And they'll still have a little inflammation towards the back of their mouth, but they're clinically so much better, eating so much better, do not show oral pain. And so I'm not going to treat redness alone with refractory stomatitis. I'm treating redness and pain. The reason confirmed exodontia is up here is because this cat had relatively significant extractions towards the back of its mouth, still had an abundant amount of inflammation, but here are what the x-rays looked like. So someone did extractions on this cat, but they left a ton of roots in here. And so these are still plaque retentive surfaces. Even though they're subgingival, they are plaque retentive surfaces. These are just foreign things in here lodged in the bone, working like splinters. So until you remove all of the root systems, I cannot call this cat, a refractory case. That's the first step, is to confirm that all the roots are out of there. So refractory stomatitis is treated similar to autoimmune conditions. We use immunomodulators primarily, cyclosporin and steroids being, the two go-tos, or at least in my circumstance. Cyclosporin, I typically start at about 2.5 mg per kg per day, 2.5 mg per kg twice a day. Some people base this on a blood cyclosporin level. I do not do that. I am more, hey, let's start at 2.5 mg per kg. And then if we're not great response, we may bump them up to maybe a 5 mg per kg or all the way up to a 5 mg per kg situation and see how they respond. I would say in my hands, cyclosporin is very successful when it comes to refractory stomatitis cases. You do want to monitor a CBC and chemistry long-term, just because you can have some anemia and renal disease with atopica or cyclosporin. I do prefer atopica. I think some of the other formulations or compounded formulations are a little bit less successful for me. And I will say that I'm not an internist, so I don't have that, massive knowledge of cyclosporin or as far as like these other formulations, but Atopic is my go-to. It is a little expensive, but my goal is that potentially these cats, some cats are on lifelong, but I also treat it like an autoimmune condition. Like I will start tapering these doses, and some cats come off of cyclosporin and steroids with this condition. But like autoimmune disease, you may have a case that represents itself with inflammation. You have to start them back on the drug. Another treatment option that we have seen is interferon omega. It impedes viral replication within the host cells themselves. So a virus gets in the cell, but which shuts off the ability for that, cell to reproduce the virus. And so a virus can't live if that doesn't happen. And so it is promising. Studies have shown that it's, positive. And I've seen cases from other dentists and other internists who have used interferon omega that have had success. The study comparing it to steroids showed no significant difference between those two treatment options, and it is really difficult to acquire right now, especially in this country. So not really something I use regularly, but it is an option. So another condition here that is relatively similar to stomatitis is canine chronic ulcerative stomatitis, CCUS, artist formerly known as CUPS. Which is chronic ulcerative periodontal stomatitis. So CCUS is same. It's an inflammatory immune-mediated condition characterized as oral ulcerations at the tooth mucosa interface, which I think is more pathognomonic in CCUS than it is in stomatitis. Is that really it's where those teeth are touching the mucosal surface, and those are called kissing lesions. The pathogenesis is not entirely understood, but it is thought to be the contact from that supragingival plaque associated with those more mucosal ulcerations. So basically, we can see over here in this picture, I think this was a Boston that had pretty, perfect kissing ulcers here. So we can see that's exactly where they're touching tooth surfaces. We see this nice ulceration here, really common around those canine teeth and sometimes those caudal teeth as well. So ulcerative stomatitis is overrepresented in Maltese, Cavalier King Charles Spaniels, and Greyhounds. Terrier breeds may also be overrepresented. I will say that I can't say that I think that these breeds are also the breeds that just have nasty periodontal disease. So I don't know that I can say that I see that more frequently in these breeds. I would raise Cocker Spaniels and English Cocker Spaniels into this group as well. I seem to see a lot of ulcerative stomatitis in those cases. Literature suggests that it may have something to do with IgG, causing excessive host response to the bacteria and plaque, so kind of mimicking stomatitis in cats. And we think that the composition of the patient's microbiome, as well as their immune response, have been studied as primary causes for this condition. But once again, there's nothing perfect as far as the pathogenesis for this. So diagnostics, CBC chemistry, urinalysis are often normal, but we can see that inflammatory leukogram and that increased globulins. One thing I do see in some of these really nasty ulcerative cases is proteinuria. And I have on multiple cases, and I'm not talking about like UPC of 5, but I am talking about UPC of like 0.5 to 0.7 even. Like they can get kind of high. And the reason that is because this causes a really nasty systemic inflammatory response that the glomerulus kind of leaks out some of that protein. So I wouldn't neglect proteinuria ever. It's something that I probably incidentally diagnosed more than I ever thought I would becoming a dentist. But I will say in cases of really nasty inflammation in the mouth, proteinuria, sometimes I take a bit more lightly until I treat the inflammatory condition of the mouth. And then I have them recheck that proteinuria because sometimes that actually improves quite a bit. Dental radiographs, similar to cats, can be normal or have severe bone loss. And biopsy is very similar. One thing is we do want to differentiate this condition from neoplasia and autoimmune conditions. So neoplasia definitely being one, similar to like what I talked about with cats. In dogs, I see a lot of lymphoma. I won't say a lot, but enough lymphoma that can mimic cups, that I've certainly put patients under anesthesia, concerned about cups, not ended up doing extensive extractions and just biopsied alone first after getting on the phone with the client, because I was concerned enough that it was lymphoma. And I've confirmed multiple cases of lymphoma in that fashion. And then also autoimmune disease. So we're talking about some of the common autoimmune diseases that can cause these kind of mucosal cutaneous interface type of erosions can also mimic. If you look here at this picture, this is a pretty good one, which you see sometimes, is this dog has nasty inflammation right underneath, the mucosa of the incisive region. And this is just like perfect. It's kissing right up against all these incisors and canines. And we see this clear depigmentation and ulceration here. That's pretty classic. So that's a good one. So the oral exam, crucial. So I would say, especially when they're coming in, even before we're under sedation, something to look at is if an owner's coming in and they're like, hey, my dog's breath got so much worse, and hey, his appetite's off. It's really easy to say, oh, the periodontal disease is really significant, because you will see nasty periodontal disease associated with this condition. But look at the buccal mucosa. And the reason that's really important, especially if you're, say you're referring that case because it does have such significant periodontal disease, and you're like, hey, to help your dog out, initially, I'm going to start on some antibiotics because I know that's going to be a temporary Band-Aid that's going to help with this periodontal disease. When you do that, these buccal ulcerations can go away. So if I see a case 2 weeks later and it's been started on antibiotics, which is a completely fine thing to do, because you're like, hey, I need to get this patient to the point where it can have more definitive care. It is going to mask what I'm looking at. And so it's important for you as a primary practitioner, or wherever you fall into the veterinary field, to really look at that buccal mucosa and confirm there's not ulcers there. Because if I see a case and it comes in and I'm like, okay, well, there's no ulcerations, and you responded so well to antibiotics, and I get them under anesthesia and I just treat the teeth that have bone loss, I could be doing that patient a disservice, because the condition's masked. I can't see it anymore. The antibiotics have reduced the bacterial population, and now I can't see those ulcers. And so I've missed the diagnosis, and that patient could represent not long after with nasty inflammation again and the similar signs. So it's important to at least notate if you're seeing buccal ulcerations. So you'll see buccal ulcerations. You may see some of those palatal glossal ones like we see in cats. I would say less common there. Lingual ulcerations are a big one that we see in cups more so, or CCUS more so than we see on the cat side of things. And you may see some really big lymphatomegaly. So you may feel that dog's mandibular lymph nodes, and boom, they're like juicy grapes. Also important, like if I feel that and I'm at all worried for neoplasia, I'll aspirate the lymph nodes as well. But you will see some really big lymph nodes there. And in this circumstance, even more than cats, the carnasial teeth and the canine teeth are the most common ones to have these ulcerations. So you can actually see in this picture over here, this is like the shape of the crown of that M1 right here. Like, oop, here's the cusp of that tooth. And it's because it's perfectly sitting and kissing up against that area. And so you want to look kind of back towards these big carnasial teeth and the canines, especially, to look for those mucosal lesions, as well as the tongue. So here are some really good pictures, and these are easy to miss because some dogs do not have the abundant buccal ulcerations, but then you open their mouth and you see this like smooth ulceration on the exterior surfaces of these tongues. And this is because that's where that tongue is sitting right up against all those mandibular teeth and just ulcerating it. Here's one that's really proliferative, and this one I think would be a little bit more obvious to us when we're taking a look there. But if you're noticing a dog coming in with tylism and nasty smelling breath and like these acute signs that we talked about, that you may present with a cups case or a CCUS or even a stomatitis case, if you're not seeing anything classic, try to look at that tongue, because I have seen cases that have come in with just the lingual ulcerations. And I would have 100% missed it had I not looked at the tongue. So that is something to try to take a peek at. And sometimes you don't even see that till they're under anesthesia. But those might be those cases where we're a little more cautious about starting antibiotics until we can get them under anesthesia and do a sedated oral exam to confirm the diagnosis. So here are some really good pictures of that. So how do we treat it? Bit of a broken record here because it's a similar thought process to stomatitis. I will say that I think that the plaque and bacteria control in CCUS is probably more successful than stomatitis in cats, because I think that you can do a cleaning, get rid of that calculus, get rid of that plaque. And because most of these lesions are so closely associated with the teeth, whereas in cats, they will have just generalized inflammation in the mouth. And so it's not as much these contact ulcers. So if I can get rid of the calculus, let those ulcers heal up, because they typically will. So once we do an anesthetic cleaning, we get rid of the plaque, those animals, usually those ulcerations resolve. So, and then you want the owner to initiate daily brushing, for sure, daily. It's not, I did it once a week or the groomer did it once every 4 weeks. That doesn't count. Daily brushing, and then anesthetic cleanings up to every 6 months. So you really have to be dedicated to mechanical removal of plaque in these cases. Once again, do not initiate medical management without a surgical plan or without at least notating. I would say these animals, I think, cause less of an issue when it comes to refractory cases. So I'm not quite as worried about the antibiotic and steroid aspect of things, although I really wish they didn't happen. They're less likely to fall into that refractory case. And so this is extractions, same as cats. What I will say with these guys is sometimes you are a little bit more successful with just removal of caudal teeth or the teeth that are directly causing ulcerations. But just because you remove those teeth does not mean you've cured the issue. You still have to initiate this very, strict daily brushing and 6-month cleaning aspect of thing. It's not good enough just to extract those teeth and set it and forget it. Like, that's not reality. We still have to treat the plaque, because just because those, you remove some of those plaque retentive surfaces, it'll just jump towards the teeth a little more rostral, after that. So you still have to be aggressive with home care. So with these guys, I will start localized extractions if they're really just focal ulcers. But if it's generalized disease, especially like that case with that tongue, like you could see the entire rim of that tongue was really nastily ulcerated, that wouldn't do anything with just removing some. So that's a closeout sale, I call that. All right. Everything's got to go. One thing that is interesting in these guys, I would say more than cats, is that rarely do they have refractory disease. So it's pretty uncommon that we do full mouth extractions on these guys and we have an issue kind of long term with them once the teeth are out. Usually this is curative, which is pretty awesome, but it's a hard conversation to have with owners. Hey, you're a young, healthy dog whose teeth are relatively pristine, who do not have significant bone loss. I need to take all their teeth out. And that's a difficult discussion. It's probably a discussion for me and less of a discussion for you guys in some circumstances. But, to me, it is one of those things where I think one of the important things to tell people is, we want to make everything like, I can't imagine a single tooth being extracted out of my head, right? Like I would not be happy with that. Dogs and cats, if they had to choose between having teeth or having nasty inflammation in their mouth, they would choose having no teeth, right? Like, get rid of the inflammation. They do really great. Aside from their tongue looking a little goofy, like the hyena from that animated show where the tongue's hanging out. Aside from that, there's very little clinical downside to an animal having no teeth. It's not what I want by any means. I'm a tooth saver, but the reality is, in cases like this where they have nasty inflammatory conditions, sometimes the closeout sale is best, and it's the best long-term thing for these pets. So I'm going to kind of end things here with a clinical case. So this is an 11-year-old Westie that presented to me. This is not the picture of her, although she was adorable. This is not her. So how she came in is she had a few-month history of oral pain and sensitivity. So she was going up to the food bowl, biting down, vocalizing. She had an aversion to hard food, would eat soft food relatively readily, but was a little hyporexic. She did have some intermittent oral bleeding. And one thing, she had a pretty good response to antibiotics. She was on multiple courses of antibiotics and initially had a pretty darn good response. And that is something that I think about, like, okay, well, all of these things are kind of lining up for a CCUS case, right? Like, I'm like, all right, check, check, check. Aversion to hard food, check. Some few-month history of oral pain and sensitivity. I'm like, okay, some of the other things I'm rolling out a little bit here if it's few months. And then intermittent oral bleeding, yep, open ulcers bleeding, and improvement on antibiotics. So we're reducing the bacterial population in the mouth. The animal's getting better. Boom, seems pretty good. So her diagnostics, she had a mild elevation of ALP, which you can show me any 11-year-old Westie, and if it doesn't have an elevation in ALP, it needs to be put into the breeding program. Remainder was pretty unremarkable. So diagnostics were kind of boring. On an oral exam, she had furcation exposure, alveolar bone loss, and mobility associated with her caudal dentition. So both her mandibular molars and her upper PM4s were diseased. She had bilateral caudal ulceration. The right was, I think the left was actually worse than the right. So, but one side was significantly worse than the other side. And she had lingual ulcerations. I'm like, boom, this is looking pretty good. Dental radiographs, severe alveolar bone loss, and periapical lucencies. Here's some lingual ulcerations here, sitting right next to that primary molar back there. So, okay, these are all following the order of what I would think for a CCUS case. X-rays, so a lot of bone loss here on the mesial aspect of this PM4. There's root exposure of the mesial aspect of the first molar. So these guys are looking inflamed. Here's a lot of bone loss on the distal aspect of this M1, periapical lucency. So, these are teeth that are sitting next to a lot of inflammation. And these radiographs, I can say, are indicative of periodontal disease, but certainly in the face of ulceration, make me think, okay, you're a CCUS case. So she did have asymmetrical ulceration. So when we talked about that, we're like, hey, when in doubt, cut it out, submit a biopsy. So here's the back left side. We can see has, very similar ulceration to the back right. But this guy was a little weird. Didn't love him. So he was a little more of a deep ulceration way back in the caudal pharyngeal region. And so I decided, okay, well, I'm going to remove these. I'm going to extract these caudal molars, as we talked about with these selective extractions in CUPS cases or CCUS cases. And I'm going to submit this little area for biopsy because I don't love it. It's a little asymmetrical. So squamous cell carcinoma. So this dog, not a great prognosis. Primarily, for a couple of reasons. I think surgery was potentially an option to remove that lesion. On a side note for squame is not a crazy metastatic tumor in the mouth. So although it's locally very aggressive, it doesn't have a high metastatic potential unless, these caudal lesions are typically more metastatic. Tonsillar, very metastatic, but, oral squame is not necessarily a death sentence if you can remove it all, because it typically mets much later in the disease. But this is a very difficult location. Like, to remove this mucosa and even to determine where are your margins, right? Because this is ulceration is extending kind of really way out in this buccal aspect. And I'm like, hey, is this ulceration the tumor? Is this ulceration CCUS? I would have to make a really kind of wide margin here. So it's a big surgery. This owner elected not to do it. What I would say is this case presented, if it quacks like a duck, it's probably a duck. And the likelihood is that this is a CCUS case that had neoplastic transformation. So just like how you can have GI disease chronically, turn into a polyp, which turns into a tumor, the same thing happens in the mouth. And so, I see this in a lot of inflammatory conditions in the mouth. Even cysts can have neoplastic transformation of their mucosa or their lining into tumors. And my suspicion is because there was bilateral ulceration, there was months history, there was a response to antibiotics, all of these things, the likelihood is this started as a CCUS case that just got out of hand and it proliferated into a tumor. That was an interesting case. And that was one of those that was like a confirmatory, hey, this is why we biopsy when we're concerned. And so that's a good gee whiz. So that's kind of all I have for you guys tonight. I know I don't even know what time it is, but it was pretty quick. But to me, I'm more than happy if you guys have any questions that we can talk about or anything, even future cases. I really enjoy what I do, and I'm happy to help you. So if you have any questions or radiographs that you can't understand or need a little help with interpretation, or even just someone to bounce something off, or a weird case, you're more than happy to more than welcome to contact. Okay. Is there questions?
There's a question in the chat. I don't know if you can see it or you want me to read it, but it says, so if you are seeing stomatitis or CCUS, but the dental x-rays don't have a lot of major changes, do you automatically extract the teeth during the dental? Or do you try a cleaning, see how they respond? And if the inflammation returns, then plan on doing full mouth extractions?
That's a good question. And I don't think that that's every case is the same. And the reason I say that is because a lot of this has to do with what is the dedication of the client. Like this is a discussion you have under anesthesia or even prior, if you open their mouth in the non-sedated, exam, is do you say to yourself, okay, this client is not at all dedicated to home care. This animal will not tolerate home care. This ulceration is really significant. Here are your options. I would say in cats, I think that I rarely offer the home care option. In dogs, if I see ulceration and there's not a significant amount of bone loss, I have a very strict conversation with them about like, hey, every 6-month cleaning, daily brushing, all these type of things. And unless they're on board, I typically will say, okay, well, then it's probably best to move forward with extractions at that time. If it's really nasty caudal inflammation in a cat, the likelihood of you fixing that with a cleaning is slim to none.
The next question is, do you see proteinuria with periodontal disease or just with those inflammatory conditions?
Nasty periodontal disease, I will say yes. Really nasty, like that first case we saw just in that opening slide where there's that bridging calculus and a ton of bone loss. Sure, if they have nasty enough inflammation that can cause systemic inflammation, you can see mild proteinuria. But I would say that it has to be abundant inflammation in the mouth for it to cause, a glomerular issue.
Another one. So closing gingiva in severe feline stomatitis can be difficult. Do you remove all friable tissue? Any suggestions on closing? Also, do these cats often have inflammation secondary to suture material?
So I will start these cats on an antibiotic post-operatively for a short course. And that is going to in itself help the inflammation in a healing process because you're reducing the bacteria, which is what we know is one of the causes of this condition, or at least what initiates some of the bad inflammation. So that helps a little bit in the inflammation itself. Really bad case, you can actually start them on an antibiotic for like 3 to 5 days prior to your extractions, and you'll be surprised at how abundantly that reduces inflammation. Some cats, even like Onsure or something like that, can be helpful with that. When it comes to the tissue, you're 100% right. Sometimes it's like closing hamburger. I don't have a perfect other than really cautious tissue handling, I don't have a great, fix all for that. Say you just want to make sure you're closing with not a lot of tension in these cats and dogs, because that tissue, like you said, is already so friable. The other thing is you will see inflammation associated with suture. I don't think it's more in these animals than it is in any classic dog or cat that has periodontal disease. I typically in these cases will use monocryl as my go-to for really nasty inflammation. It hangs on long enough. But one thing you can consider is that in some of these cases, if I'm having an area where I'm a little bit worried about suture pull through, I'll consider using a cruciate suture, because it's almost more of a mattress and it helps with a little bit of tension release, and you don't get as much tear through in some of those circumstances. But that's uncommon. I do that, but that is something you can have in your back pocket if you're really worried about suture pulling through, because the tissue is
All right. Another question. Also great questions. If the owner is interested in trying home care for CCUS or feline stomatitis, do you find chlorhexidine oral rinses to be helpful in addition to daily brushing? And if yes, is there a brand that you prefer?
I think Verbac has a brand that I use. But I will say it is not good alone. In combination of mechanical brushing, yes, I think it can be helpful. And even in those circumstances, we talk about like water additives can also be helpful in those circumstances, but they are not helpful alone. They need to be in combination with mechanical brushing. And if you go on the Oral Health Council, the Veterinary Oral Health Council, there's a website, and basically the Veterinary Oral Health Council has looked at all of those products and has recommendations on to which ones we've looked at and that can work. But it's important to tell people like, hey, no water additive, no chlorhexidine works by itself. You must have the mechanical brush first. And then that secondary aspect of chlorhexidine or some sort of bacteriostatic type of or antiseptic is beneficial after that, but not by itself. That's a bit like only doing mouthwash every day and not brushing your teeth. Like, it doesn't work. It won't penetrate the biofilm.
All right. What are the questions you guys have? Those are all the ones from the chat, but I see a lot of people are still logged on. How about oral health probiotics in addition to recommended to the above added and mechanical? So any oral health probiotics?
Good question. I don't know that I've ever used an oral health probiotic, to be honest with you. So I would not be the person to ask about that. I don't. The problem, I think, is that with a probiotic, it's any bacteria it's responding to. I think we don't know that it's just virulent bacteria that they're responding to. So to me, I don't know that probiotics would be of great benefit just thinking about the pathogenesis of disease. So I'll leave that to someone who knows more about it. But personally, I don't use probiotics in the mouth as a benefit, or at least I don't have enough reference point to tell you that's good or bad.
And then I feel bad having an owner administer antibiotics orally to a feline stomatitis cat. What do you do?
Give it an injection of convenient. Like if you're in a standpoint where you have a cat that's post-operative and you've done full mouth extractions and they are so sensitive in the mouth, I think if I'm not a hater on that drug. I don't think it's worth doing every 4 weeks, right? Like, I'm not going to abuse that drug, but in the short term, if you're trying to get them through to surgery and they will not tolerate an oral antibiotic and you don't have a lot of choice, or you're post-operative and you don't want them oral administration of antibiotics, I don't think convenient is a bad option. It definitely will help, and I don't think it's a crutch. You shouldn't be using it regularly or, constantly in the same patient. But I think it's helpful when you have a patient that is post-operative and they do not want you manipulating their mouth. In a cat, I would say it's uncommon. I use it in a dog, but in a cat, I think that can be helpful and it can help reduce the inflammation. But I agree with you. I think that manipulating the mouth and forcing drugs down a cat who just had all its teeth taken out is probably not the most ideal thing. So, it's not perfect, but it's a good option.